Welcome back to I Am Bites, the resident-led podcast bringing you short, evidence-based clinical updates for internal medicine. My name is Liz Karanja, a resident at The Ohio State University Wexner Medical Center.
And I'm Emily Duncan, another resident at The Ohio State University Wexner Medical Center. Before we start, a quick reminder. Please complete the brief pre-episode survey linked in the show notes. It takes under 2 minutes, it's anonymous, and it's how we measure what this episode is actually doing for resident learning. Please complete this before listening to the rest of the episode.
Today's episode is from the GI Committee. We're talking about colorectal cancer screening from the updated 2021 guidelines and recent studies, and what to actually offer your patients.
Please note the thoughts and opinions voiced in this podcast are ours alone and do not necessarily represent the views of The Ohio State University Wexner Medical Center. The contents of this podcast are for educational reasons only and should not be considered medical advice. Imagine you are in clinic seeing Jane, a 45-year-old woman with type 2 diabetes and tobacco use. She has no family history of colorectal cancer. She heard from a friend that she should be screened and wants to talk through her options.
I'm so glad we're discussing colorectal cancer screening. With limited time in clinic visits, it's easy to move on if someone declines screening. But colorectal cancer is highly preventable and very treatable when detected early. Encouraging screening is so critical to catching colorectal cancer early and improving outcomes. Let's first talk about who gets screened and at what age we start screening.
In the 2021 updated guidelines, average risk screening age was lowered to 45. Average risk, meaning no personal history of polyps and no family history of colorectal cancer or advanced adenomas. Family history means a first-degree relative, such as a parent, sibling, or child.
So for Jane, who has no family history, we should start screening now. How does this change if her dad was diagnosed with colorectal cancer at age 45?
Think of it this way, Liz. If you have a family history of colorectal cancer, start screening in family members at age 40 or 10 years before the relative's diagnosis, whichever comes first. So if her dad is diagnosed at 45, Jane should have started screening at age 35. And family history does not just include colorectal cancer. Advanced polyps count too.
Now that's something I didn't know. So what makes a polyp count as advanced?
Same here. An advanced polyp is any adenomatous polyp with one or more of these criteria. 10 millimeters or larger in size, tubulovillous or villous histology, or high-grade dysplasia on pathology. If a first-degree relative has any of these, patients should be screened at age 40 or 10 years prior, whichever is earlier.
So just to recap for our patient Jane, if her dad has a 15 millimeter villous adenoma at age 50, she should start screening at age 40?
Exactly.
And at what age do we stop screening?
Well, this should be individualized. The American Cancer Society supports continuing through age 75 if life expectancy is at least 10 years and if the patient can tolerate the procedure. Past age 75, it's shared decision-making because the benefit shrinks as the risk of those colonoscopies climb. Now we know who to screen. So let's discuss next the different kinds of screening modalities that exist. We will be citing comparisons of these tests from the 2025 American Gastroenterological Association, the AGA, Clinical Practice Update.
But before we discuss the different screening modalities, I think it's important to highlight that the most important screening test is the one the patient is willing to complete.
Yes, that's such an important emphasis to make, Liz.
The 2021 guidelines from the American College of Gastroenterology stratifies colorectal cancer screening tests into Tier 1 and Tier 2 options. Tier 1, or the preferred screening tests, includes colonoscopy and the fecal immunochemical tests, or FIT. Tier 2 includes second-line options such as stool DNA testing like Cologuard, CT colonography, flexible sigmoidoscopy, and colon capsule endoscopy.
That's right. And of the Tier 1 options, colonoscopy is the gold standard. It is a one-step screening test, meaning in one test you get both diagnostic and therapeutic options. If a polyp is found, it gets removed. If normal, colonoscopy should be repeated every 10 years or every 5 if there's a first-degree relative with colorectal cancer.
And FIT is a recommended two-step test, meaning it screens but cannot diagnose and is not therapeutic. FIT is a stool test that detects human hemoglobin from bleeding polyps or cancers. If it's positive, then you need to follow it up with a colonoscopy. A lot of patients may prefer this test, but it is important to discuss with them the lower sensitivity of FIT compared to colonoscopies in our head-to-head trials.
Does FIT detect advanced adenomas?
That's a good question. While FIT can detect some adenomas, its sensitivity is relatively low and it performs poorly at detecting serrated lesions. In other words, it can miss precancerous lesions that have the potential to develop into colorectal cancer. That's an important limitation to discuss with patients when considering FIT as a screening option for them.
Great. And another point to remind patients is that FIT has to be repeated every year.
All right. So, what if Jane declines the colonoscopy and the FIT? What alternative tests could I offer her at this point?
Well, again, the best test is the one the patient will actually do. Because of this, the American Cancer Society recently released new guidelines and updates for colorectal cancer screening, which includes multi target stool DNA testing and blood based tests.
The multi-target stool DNA test, also known as Cologuard, detects abnormal DNA shed from colorectal cancers and advanced polyps, along with the hidden blood in the stool. Patients receive a collection kit at home, collect a stool sample, and mail it back to the lab for analysis.
How does this compare to FIT tests?
That's a good question. Empty stool DNA tests detect 92% of colorectal cancers compared with 74% for FIT, making it more sensitive. It also outperformed FIT for precancerous lesions, 42% versus 24% sensitivity. However, it had lower specificity than FIT, 87% versus 95%, resulting in more false positives. That said, colonoscopy still remains the gold standard for advanced adenomas.
Exactly. And because it's a two-step test, a colonoscopy is needed anyway if you get a positive result. This also creates a few weeks of anxiety for your patient before they can get into the endoscopy suite, and is why it's also important to discuss this with your patients if they are truly considering an empty stool DNA test.
Right. And just a reminder that stool DNA tests should be repeated every 3 years.
So, why might someone refuse or be unable to complete Cologuard?
Another great question. Some patients may have difficulty collecting a stool sample. Insurance coverage can be affected if the correct diagnosis code isn't submitted, and there can be logistical issues when returning the kit to the lab.
Ah, yes. Okay. Those are important considerations. Not everyone will have success in completing stool tests. All right. Now, what should we know about blood based tests for colorectal cancer screens?
Yeah, so these are new emerging tests that are options for patients who decline both colonoscopy and stool-based testing. One test, the Shield test from Guardant Health, was FDA approved in 2024 and is now covered by Medicaid. What should we know about the performance of this blood test compared to colonoscopies and stool-based tests?
Blood based tests detect about 83% of colorectal cancers, but only 13% of advanced precancerous lesions.
That sensitivity for advanced adenomas is extremely low.
Right? In comparison, MT stool DNA detects 42% of advanced adenomas, as we've mentioned, while colonoscopy detects about 95%, why it's the gold standard. So while blood-based tests are a promising option for some patients, they still just don't match the performance of colonoscopies or stool-based screening. And many providers are not convinced yet because of this.
So just to recap, 3 takeaways for your next clinic shift. 1, start average risk colorectal cancer screening at age 45. 2, if a first degree relative had colorectal cancer or an advanced polyp, start screening at age 40 or 10 years before their diagnosis, whichever comes first. 3, colonoscopy is the preferred one-step screening test, while empty stool DNA, i.e. Cologuard, has the best sensitivity for colorectal cancer and advanced adenomas compared to FIT. Blood-based tests are available, but sensitivity remains low, especially for advanced adenomas.
We can't emphasize enough. The best screening test is the one your patient will actually complete. That's why it's important to discuss all these screening options during annual physicals. Colonoscopies can be logistically challenging, requiring transportation to and from the procedure and someone to accompany the patient home because of sedation. For patients without reliable transportation or a support person, alternative screening options may be more practical.
Agreed, Emily.
To our listeners, one quick ask. Please complete the brief post-episode survey linked in the show notes. It's anonymous, it takes about 2 minutes, and it's how we know whether this episode actually changed anything for you in clinic.
Thanks for listening to Iron Bites. Stay tuned for the next episodes.